Assalamualaikum. Assalamualaikum.
Waalaikumsalam doktor.
Assalamualaikum doktor.
Okay. Tisat dengan Fatihah. Mama. Ejak. Okay, since kita buat online, so you guys can present 2 cases that you've clocked, including the physical examination. Kejap. Give me like 1 minute. Kejap je, ambil earphone je. Okay, habis start lah. Can start.
Assalamualaikum. My name is Wanra Atira and I'll be presenting about Zara, a 2-month-old girl, came to the ward due to paleness for 1 day duration. It is a recurrent episode of paleness since birth and the onset is gradual. The mother noticed the paleness on her lips and the hand is cold to touch. The mom denies any fall, trauma, or any blood loss. There is also no blood in the stool noted. There is also no coughing out blood. It was associated with jaundice, but no interrupted feeding. It is severe as the mother stated that her lowest HB level was 7. Antenatally, the mother had polyhydramnios. She was born term with a weight of 2.50 kg via SBD. The mother claims that her jaundice appeared at birth with the reading of more than 300 gram per deciliter. She was admitted in special care units, SCN, right away and received blood transfusion. She had jaundice for 9 days. Other than that, she had been receiving blood transfusion for 4 times in SCN. Pre-transfusion HB level is about 7 gram per deciliter and post-transfusion hemoglobin level is 12 to 13 gram per deciliter. However, the HB level will drop again after 2 weeks of blood transfusion. The latest blood transfusion was 6 days ago, which was on the day of admission. The mother and the patient's blood type was O and A respectively. The patient doesn't have any loss of appetite and loss of weight. The mother doesn't notice any abdominal distension. There is also no travel history as the patient spends most of her time in the hospital. She actually just got discharged from SCN, 1 week at home and then admitted to the ward again. The urine and stool color is normal. The urine color is yellow. The stool color is sometimes yellow, sometimes green, normal. The parents have done thalassemia screening. And the results were negative. There's no G6PD. There's no family history of G6PD deficiency, Fanconi anemia, or autoimmune disease. For the systemic review, there's no fever, no rashes. There's no cough, no coughing out blood, no noisy breathing, no cyanosis, and no shortness of breath. For GI, no vomiting, no diarrhea, no dysentery, no constipation. Neuro, there's no seizure, no abnormal movement. For immunization, there's only BCG is done. Hep B vaccination is not done yet due to her anemic condition. For the feeding history, she drinks formula milk 2 ounces 4 times a day. Also with breast milk also. For the developmental, for the gross movement, she still has head, leg. For fine movement, eyes can follow object. Speech, she can squeals to delight. And social, she can smile. For past medical history, she has congenital heart defect. And actually it causes poor weight gain at the asalnya, but now but she has done surgical closure of the VSD 1 month ago. There's no complication. For past drug history, she took furosemide, captopril, and spironolactone. For past family history, I mentioned that there's no family traits. There's no thalassemia traits in the family. There's no GSPD deficiency. Social history, the father works as police and mother is a housewife. They live in Bera. She is the 5th child. The father is a smoker. For the physical examination, I didn't count the respiratory rate and pulse rate. The hands are cold. The capillary refill time is less than 2 seconds. There's no conjunctival pallor. There's no jaundice in the sclera. I look at the chest, inspect the chest, and there's sternotomy scar, about 7 to 8 cm. It is still red. It is not healed yet. For the abdomen, there's no abdominal distension. There's no scars in the abdomen. It is not tender on palpation. There's no abnormal mass palpated. It is resonance on percussion. Also, there's no hepatosplenomegaly. The kidneys are not bloatable. I also auscultate the lungs. There is prolonged expiratory phase. And for the cardio, it is normal heart sound S1 and S2. For the differential diagnosis, this case is quite complicated. So I think the provisional diagnosis is, it might be hemolytic disease of newborn. Or maybe the mother doesn't really tell well about the thalassemia. Maybe she doesn't check. So the diagnosis could be alpha thalassemia. And then others is ABO incompatibility, or maybe inborn error metabolism such as Crigler-Najjar syndrome. For investigation, do full blood count to determine the type of anemia. Also do a full blood picture to check the abnormalities of the red blood cell. Also check screening for thalassemia and G6PD deficiency and IEM screening test. That's all from me.
Okay, okay, good. Any comment? Anyone want to give any positive comment about the presentation? Anyone?
But doctor, this case, I think it is so complicated. Even the diagnosis in the ward, it said anemia for investigation. So is it through my differential diagnosis? Does it acceptable?
Tadi apa? Saya yang differential tadi I tak dengar. Saya tengah cakap dengan orang. Sorry. What's the differential? I dengar thalassemia aje.
Differential ada alpha thalassemia, hemolytic disease of newborn, also inborn error metabolism, Crigler-Najjar syndrome.
Crigler-Najjar. Mana you dapat Crigler-Najjar?
Sebab ada jaundice.
Okay, Kriegler Najjar ni is a spectrum, dia ada two type. Dia type 1, type 2. Kriegler Najjar ni datang dengan conjugated hyperbilirubinemia. So patient ni conjugated hyperbilirubinemia ke?
Tak check.
How can you tell? you don't need investigation. Of course, you confirm by investigation. But from history, how can you tell this is conjugated or unconjugated?
Distended abdomen. Hepatomegaly.
No, that doesn't tell you this is conjugated or unconjugated. What is the difference between conjugated and unconjugated hyperbilirubinemia?
Conjugated can cross the blood-brain barrier, and I think the difference, it can cause cardiac arrest.
That is true. Okay, that is true. But by clinical, how can you tell this is conjugated or unconjugated? Kalau conjugated, what happened? How about the urine? How about the stool? Is there any difference?
There's no difference in the urine and stool.
No difference in the color?
Sekejap.
Okay, why not? One of you, I nak assign siapa Okay, Nadira lah, Nadira Aziza. So Nadira Aziza, can you, while we discuss, can you search on internet how to differentiate conjugated and unconjugated hyperbilirubinemia by clinical? Means by urine color ke, stool color ke, by physical ke, things like that. Can you differentiate, or any clues in the history of physical examination can give you clues on ni lah, either this is conjugated or unconjugated. So Nadira, nanti you baca I give you like 5 minutes. Once you settle, you can tell us. Okay, so get back to your ni. Kenapa alpha? Why specifically alpha, not beta?
Because it appears early, 2 months.
Is
She's
it
2 months
really
old.
alpha? What type of alpha are you talking about? Are you talking about 4 gene deletion, 3 gene deletion, or 2 gene deletion, HBH disease?
I don't know.
Okay. So you said alpha thalassemia, Kriegler Najjar, and then one more is
Hemolytic disease of newborn. But this is
hemolytic disease of
on
newborn. Okay, what is the other name of hemolytic disease in newborn? Hemolytic disease in newborn is a spectrum of disease. Okay, it's a disease. The pathology is the same, which is hemolysis of the blood, but the etiology is different. The most common cause is ABO incompatibility. Okay, we call it ABO incompatibility. Hemolytic disease in newborn, secondary to ABO incompatibility. That's the most common. But usually the main presentation is not hemolytic disease in newborn. They don't present with anemia. The main presentation is jaundice. Okay, rarely it causes severe anemia. Okay, because for example, like GSPD diffusion, you don't say this. It's not considered a hemolytic disease in newborn. It is a hemolysis disease, hemolytic disease, but hemolytic disease in newborn, usually the cause is we call it alloimmune, alloimmune lah, alloimmune punya hemolysis, which mean usually the most common is ABO incompatibility, but the most severe form is rhesus incompatibility lah, rhesus negative, infant of rhesus negative mother. That is rhesus incompatibility. That's the most common and the most severe, and the most common is ABO incompatibility, and it doesn't goes beyond 14 days in term. It doesn't goes beyond 21 days in preterm. So kalau dah 2 months, it cannot be hemolytic disease in newborn. Nama pun newborn kan, this is 2 months already. So what else? Okay, so let's talk about the diagnosis later, but let's focus on your presentation. Any comment from anyone? What do you think about Atila punya presentation? Is there any like points that you want to learn and you want to take home and like you want to practice or you want to imitate ke? Any techniques that you think is very interesting and very like smart technique lah yang you nak apply. Anyone? Of course there must be some good kan, something good. Chat. Takkan tak ada, takkan teruk sangat presentation dia. I think it's quite a good presentation. I think. Feedback. Chat.
I think it's good because she asked her parents about the thalassemia if they have checked before, so it's negative in case they are the carrier for thalassemia.
Okay, important, good. So there important family history are there. Okay, good. Again. What else? Again. Siap. Tunggu sekejap. Pergi. Okay, what can be improved? Or what can be done better? Anyone? Come on, pergi mah. Jom.
I think doctor at the end of the presentation should put the summary of the cases.
Okay, good. Okay, especially for complicated case like this, you need to provide a summary. Okay, that's good. Lagi, what else? Anything else?
I think before starting the physical examination, maybe she can check how the child looks like. If there is any features of thalassemia like frontal bossing or the general appearance of the baby.
Okay, that's very true. Okay, that's good. Okay, it's very important clue kan. Okay, okay, next. Okay, sekejap, boleh tak bagi I 5 minit? Kejap je, sorry. Kejap. Sempat ni bising sangat lah. Kejap. Okay guys, okay, sorry lah, sorry. Okay, so basically the presentation is okay. However, it's a bit, I think it's a bit unstructured lah in a way. The arrangement tu macam, the flow tu is a bit unstructured sikit. You can improve on that. For example, like focus on the presenting complaint, the history of HOPI, and continue with the rest lah. And then in terms of history, when you presenting a very complicated case kan, it's good and you want to focus on one aspect of the problem kan, because now the patient got two major problem. One is congenital heart disease kan, and the other one is anemia. But you want to focus only on the anemia kan. So on anemia. So what you can do is you clear up the other problem. So you can start out with this is blah 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 with underlying congenital heart disease to VSD who underwent surgical correction, who's currently on anti-failure. Contoh macam tu. And stop there. And then now I'm going to discuss about, now I would like to talk about the problem of anemia. She was first presented with blah 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 blah. Ataupun this time she was admitted for pelo. This is her berapa blah 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 blah. Okay, faham tak? This is her third presentation, third admission with similar presentation of pelo. Okay, faham tak? Faham kan?
Faham
You guys
Doktor?
dengar tak? Dengar kan? Okay. So that's how you do it, because if not, it causes us confused tau. It make confusion. Macam I'm really confused with the story actually. Sebab you start out with anemia and then tiba-tiba ada congenital heart disease. So what are we talking about? Are we talking about something genetic in nature or something macam tu lah? Okay. That's number one. Number two, the physical examination, I do agree with your friend. There's few other things, important points that you miss. For example, macam tu lah. Apa namanya? There's thalassemia phases. On top of that, patient who came with two major system pathology in two major system like this, you have to think of genetic. Okay. For example lah, you've got a patient who came in with short stature, skeletal deformity. On top of that, ada anemia, ada bleeding punya problem. Ataupun you've got a patient with congenital heart disease. On top of that, with bowel punya problem. So there's two major system kan. Usually when it involve multiple system, you have to think of along the line of genetic or syndromic problem. Okay, faham tak? Faham tak?
Faham Doktor?
Okay. Okay, so that's it. Ada sesiapa lagi nak tambah ke?
Doktor nak tanya, kan dia ada jaundice waktu lahir kan. So saya include birth history dalam HOPI, tak apa tak?
Ideally, okay, if you want, to me, I don't like my HOPI to be mixed up with other element of the history. For example, I tak suka my HOPI ada cakap pasal apa? Ada involve past medical history ataupun ada cakap pasal immunization history in HOPI. HOPI should be left as it is. Just focus on HOPI. However, okay, if you want to include important history that you think important, for example, you rasa family history is very important ataupun the birth history is very important, you can mention it but not within the HOPI. You mention it earlier than the HOPI. Contoh kan, you will start out, you should mention earlier, even before than presenting complaint. For example, you boleh kata macam ni, you boleh cakap, I would like to present about a case of Ali who had history of severe neonatal seizure and neonatal jaundice during neonatal period, who presented with pelo. Faham tak? You tak boleh mention contoh you kata the pelo is associated with contoh with reduced oral intake. Contoh lah you kata with reduced oral intake and then with diarrhea, vomiting, and then suddenly you kata patient had history of severe jaundice. Lepas tu you sambung pula you kata and then patient also got weight loss, constitutional symptoms. Faham tak? So you cannot do that. Faham kan? Faham kan apa cakap kan? Okay. HOPI should be left as it is. Kalau you nak cakap something else, then you cakap before or after the each of the components lah, HOPI ke ataupun before family history or before immunization history. Okay, faham kan? Okay, ada soalan tak? Okay, let's satu kan. As I've mentioned, because this patient presented with two different systems altogether. So you have to think of genetic. So when it comes to genetic, on your physical examination, you can mention, is there any dysmorphism, facial dysmorphism? Facial dysmorphism, you can mention. And then, Uma? Facial dysmorphism, you can mention. And then you can cakap juga pasal ada satu, because this is something yang chronic kan, dia ada betul congenital heart disease, so you can mention juga about the growth. Okay, so it's very important lah, you can sebut growth dia, weight dia gaining ke tak, and then on physical examination, how do you see the child look cachexia ke, look wasted ke, because it is very important lah to determine the control, how well is he post surgery and so on. Okay. Okay, ada soalan tak before we discuss the differential diagnosis? Any questions? By the way, at your level kan, it's good to discuss, to present case yang quite straightforward, ataupun ada, if complicated case pun dia ada satu pathology je. Because if multiple pathology, for training purposes, it's quite difficult. Okay, maybe year 5 better lah. Tapi kalau you nak discuss in your case summary or case write-up, then that's okay. Tapi for the purpose of like clerking or presentation training, it'll be a bit difficult. Okay, faham tak? But it's good. This kind of cases is very good for you to learn. Okay, when it comes to differential diagnosis or diagnosis, you have to try your best to explain any pathology with one diagnosis. For example, this child dia ada congenital heart disease, dia ada anemia. On top of that, dia kata, contohnya kata dia ada severe jaundice, it's hemolytic anemia. Then is there any disease that can explain all of this together? Because it's very rare, and Allah tu is very merciful. Allah is very merciful. Dia tak test someone with multiple illness. Usually it's one after another lah. Contoh kalau orang yang sakit jantung, dia tak dapat macam complication diabetes, complication jantung, complication heart attack, stroke, semua all together. Because Allah ni is very merciful. They test one after another. Okay, and it depends on the level of iman lah, our level of iman. So try your best to conclude and try to explain all the problems with one diagnosis. So ada tak diagnosis yang with one diagnosis you can explain the congenital heart disease, you can explain the severe jaundice, or you can explain the recurrent anemia? Any?
Sickle cell anemia.
Sickle cell anemia. How sickle cell? Is it common sickle cell presented with BSD? Is it sickle cell common in Malays? Malays kan? Tak ni? Ke Nigerian? Malays kan? So it's not common kan? So I don't think sickle cell is at the list. And besides, sickle cell, they don't present this early. Remember, thalassemia, they don't present this early. Except for few cases of thalassemia yang very rare. common thalassemia like beta, alpha memang tak akan present lah umur macam ni. It's mustahil untuk alpha present umur macam ni. Okay, alpha thalassemia dia presented at the age of usually 6, 7. Dia tak. HBH disease is a intermediate. Alpha thalassemia is always intermediate. It's not a major. Okay, dia bukan macam beta major. Even beta major pun dia present after 6 months. So if a child presented this early, the top at the diagnosis of your diagnosis should be something to do with marrow problem. Okay. Tapi kalau dia ada hemolysis on top of that, then it's unlikely to be marrow. It must be something to do with peripheral brain destruction. Kau tak kenapa dia hemolysis? Kan? Ataupun mechanical destruction. Contoh, I tak tahu what sort of surgery yang dia buat. Tapi sometimes, kalau this patient is a bit older, adult, I would say possible with heart problem and then on top of this anemia and also jaundice, I would say this is post mechanical valve replacement and then complicated with anemia and hemolysis. Faham tak? Because dia baru operate, tukar mechanical valve, and then mechanical valve tu causing anemia and hemolysis. Tapi because this is 2-month-old boy, and then memang dia ada hemolysis lah, dia ada jaundice. Currently ada jaundice lah.
Dan dia sebelum
Maksud dia datang
surgery
with
lagi
anemia
ada.
and jaundice.
Bukan. Jaundice tu waktu lahir 300 tu.
Waktu lahir kan. Currently tak ada jaundice kan?
Tak.
Then because it's very rare to get a child beyond neonatal period datang dengan hemolytic jaundice, hemolytic anemia. It's very rare. Most of the time it's anemia because of illness, because of nutritional anemia, or because of marrow punya problem. My suspicion is patient ni ada what we call it, either transient erythroblastopenia of infancy. The problem with marrow tak boleh, dia ada problem dengan erythrocyte punya production, or dia ada some kind of marrow failure, ataupun dia ada some kind of diamond blackfern syndrome possible, ataupun dia ada aplastic anemia. Cuma because dia ada major heart problem, my first stop in my diagnosis would be Fanconi anemia. Provided dia memang ada syndromic phasis and also dia ada skeletal deformity. Tapi these things you need to learn lah. Of course you need knowledge. Kan, contoh dia mesti tak ada thumb, ataupun dia tak ada thumb lah. You check dia ada 4 jari ke 5 jari. Because you didn't present in your presentation, in your physical examination. So susah lah I nak conclude. Tapi this is the thing on my mind. These are the things along the genetic lah. But it has to do something. It has to do with genetic.
I put in my differential Fanconi anemia, but I didn't present because I thought it is macam tak
Okay,
logik.
what you can practice kan? Actually, what you can practice, okay? What you can practice kan, as a student kan, bila you come across cases, okay, you boleh balik, you boleh fikir apa dia diagnosis. And then you baca, what are the differential diagnosis? Contoh alpha. And then you tengok, alpha ni match tak dengan patient ni? Kenapa match? Apa tak match? And then contoh, you baca alpha, alpha dia mesti ada some frontal bossing. So you balik, the next day you jumpa patient, check dia ada tak frontal bossing to support alpha? Okay, tak ada. And then Fanconi. What are the physical sign of Fanconi? What are the type of history datang dengan Fanconi? Fanconi dia mesti ada renal problem. Fanconi ni is very bad tau. It's a multi-system problem. So you tengok. And then dia pergi balik kat patient, dia ada tak all these features of Fanconi? Dan kalau dia tak ada all these features, history pun tak suggestive, then you move out. Macam Cleveland aja dia totally normal. Cuma dia ada conjugated hyperbilirubinemia. It depends on what type 1, type 2 lah. Kalau type 1 tu memang very severe. And then it's quite rare. Dia conjugated hyperbilirubinemia in neonate kan, in newborn. Usually it's something to do with structural lah, ataupun dia tak resolve simply macam tu. Kalau dia macam ada history of neonatal jaundice and then now resolve, most likely is unconjugated. Okay. If it is unconjugated, definitely Cleveland aja bukan the diagnosis. Itulah. It's a bit complicated, I know. Tapi itulah. Ada soalan? Ada soalan? Soalan tak? Sorry lah, macam tadi sorry tadi I bawa anak I ke klinik. So tunggu beratur, lepas tu tunggu ambil ubat semua. Jangan lambat sikit. Okay. Ada soalan tak? Ada soalan tak? Lagi satu kan. If you think it's very complicated, another way to help you with your presentation kan, you boleh start out with, okay, I've Clark Abu, okay, blah blah blah, two of Clark Encik Aminah, Encik Ali, father of Abu, 2 months old boy with few medical problems. Number 1, congenital heart disease. Number 2, recurrent anemia since neonatal period. Contoh recurrent anemia since neonatal period. Number 3, apa dia? History of neonatal jaundice. Okay. Then first you start out. I would like to discuss about the neonatal jaundice. About the anemia. Faham tak? You can do that. So you kena focus. You tak ada masa lah. You don't have enough time to present everything. This is not like traditional long case. Yang you ada sejam untuk present. Okay. Okay, ada soalan? Tak ada? Complicated kan? Tapi it's good. It's good for your training. Kalau I suka patient macam ni. So datang suspect lah. Ni kan ada OSAS ya? So dia refer suspect lah. Suruh dia refer suspect. I nak tengok patient ni. Okay, next.
Okay, Assalamualaikum. My name is Nur Anis. So my patient is Arisa, a 2 years and 7 months old Malay girl, was presented to emergency department of suspect due to the rapid breathing on the day of admission. So the child was well until 4 days prior to admission, where she had fever, and the fever was a low-grade fever, and it is warm on touch and reduced with the temperature reduced with tepid sponging, but the temperature increased again after a while. And she also had cough, where the cough is productive cough and worsened at night. And she also had runny nose with clear discharge. 3 days prior to admission, the child was given medication from the pharmacy, and the fever and runny nose resolved. However, the cough persisted. She also had 2 episodes of vomiting, and the vomiting was described as mucus and watery, and the consistency is 2 episodes of vomiting. So on the day of admission, the child was having rapid breathing associated with noisy breathing and chest pulsation subcostally at 5 a.m. So the child was brought to emergency department and was given nebulization and MBI salbutamol. And there is history of feeding pigeon in the city for 2 days. So for past medical history, the immunization was up to age.
Assalamualaikum. Internet problem
Internet Anis problem.
Sekejap, I nak buat phone call kejap je.
Hello, can you hear me? Can you hear me?
Yes.
Okay, so
Okay, sama-sama.
So for the past medical history, the immunization was up to age. The child has a history of allergic rhinitis. However, there is no eczema and asthma. This is the second hospitalization, where the first hospitalization was last year due to the upper respiratory tract infection, and the child was hospitalized for 4 days. And this is also the second history of nebulization, where the first one is during the first hospitalization. And there and no drug allergies. And the mother, for the birth history, the mother had no GDM, no hypertension, and no other complication during pregnancy. And the child was delivered at Susmek on full term via spontaneous vertex delivery with birth weight of 2.3 kilogram. Postnatally, the child had jaundice for 2 weeks and was warded for 2 days. For the nutritional history, the child was exclusively breastfed until 1 month because of lacking of milk, and then continue with formula milk. And the weaning start at 7 months and now present with adult diet. And the development was up to age. For the family history, the father is a soldier and the mother worked at a restaurant. And the child was the only child. And the father had diabetes mellitus, the mother had allergic rhinitis, and grandparents had diabetes mellitus and also hypertension. I missed one in the past medical history. The child also had allergic rhinitis. So for the social history, they live at Indra Sampurna, a housing area with good water and electric supply, and also good hygiene, and no construction near the house, and it is away from the main road. There is no cat in the house, no smoker in the house. And for the physical examination, I can't do the full examination as the child was very active and uncooperative. So upon observation, the child was well, pink, alert, active, with good hydration status. However, she is not cooperative well. There is no cyanosis and also no clubbing. So for the auscultation, there is scattered crepitation, scattered crepitation with no ronchi, no wheezing, no reduced air entry, no chest indrawing. And on palpation, the chest is symmetry. There is no chest. There is no scars, no chest deformity, and the child is not tachypneic and not in respiratory distress. So I would like to complete my examination with vital sign, blood investigation, chest X-ray, and also pulse oximetry. For summary, Arisa, 2-year and 7-month-old, Meliger was presented to emergency department of Susmek due to the rapid breathing on the day of admission. And the rapid breathing was associated with fever, cough, runny nose, and also runny nose. Upon examination, the child was being alert and active. However, on auscultation, there is scattered crepitation. For my provisional diagnosis is viral pneumonia, and the differential diagnosis is asthma and acute bronchiolitis. I think that's all.
Okay. Sorry, I ada patient pula nak datang, 2 orang. Anyway, I a bit confused lah. Patient ni datang dengan diarrhea, vomiting kan? Kan the presenting complaint is what?
The chief complaint is rapid breathing. There is no diarrhea.
You sebut no diarrhea tadi. Okay. So, I dengar macam dia kata ada diarrhea. Okay. Tak you sebut konsistensi kan? Dia sebut diarrhea tadi. Diarrhea ni konsistensi you ada sebut. Tak ada
The child had diarrhea 2 days prior to admission, 2 episodes. Sorry, not diarrhea, vomiting.
Vomiting. Okay, betul. Okay, that is 2 days prior to ni lah. Okay, so the main problem is rapid bleeding. Okay.
Yes.
Okay lah. How old is he again?
2 years and 7 months.
2 years and 7 months. Okay, so any comment?
I think I got a bit confused for the past medical history. She includes immunization.
Okay, good. Okay, past medical history should be separated lah. You should at your level, I think it's better for you to mention the heading. Okay, past medical history, blah 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 blah. Immunization history, she's blah 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 blah. Okay, buat contoh. Okay, lagi.
Does the patient had asthma? If yes, how did the mom control the asthma at home?
The patient doesn't have any asthma, but she had allergic rhinitis.
How about atopy? You mentioned ke tadi atopy history? History of atopy.
Atopy history, just allergic rhinitis and no drug allergy. No
Tak,
other
itu yang
allergy.
patient family je.
Family, the mother had allergic rhinitis.
Mother apa? Ada apa?
Allergic rhinitis.
Okay, mother ada. I think overall, I think the presentation is okay, except from bila start tadi tu, I rasa ada few things that I missed waktu you hang tadi, waktu you ada problem internet. And then bila continue tu, I miss the totally the part tu lah. Tapi prior to that and after that, I rasa it's okay. Your flow pun is okay. Cuma tu lah macam Atira mention there, ada some flow yang macam tak okay sikit lah. Tapi otherwise, in general, is okay. And this is quite a simple case, so we can follow through the presentation lah. Cuma when you come to differential diagnosis, tadi first you said this is viral pneumonia kan? Why you say this is viral?
Because she had fever and also the age is 2 years, so common in pneumonia than in bronchiolitis.
Okay.
Bronchiolitis.
Okay. Lagi no fever. Okay, lagi. Your differential is apa?
Asthma.
Asthma. Why not asthma?
Why not? Because this is the first presentation of rapid bleeding.
Okay, good. Okay, and then you say bronchiolitis kan?
Yes.
Bronchiolitis kan? So bronchiolitis memang out lah memang tak boleh lah. Definitely bukan lah bronchiolitis. Yes. Sekejap. Wait. Sekejap. Susah lah. Okay, so bronchiolitis bronchiolitis tak lah sebab this is more than 2 years old kan. But those I do agree lah, you punya differential of viral pneumonia and also asthma tu not so lah. Asthma tu maybe tak berapa tepat kan. What else? Tak banyak lah differential. Another one is just a bronchopneumonia. Cuma unlikely sebab dia tak ada fever. And
She had fever, Doctor. Low grade fever.
benda macam tu lah. Wheezing episode wheeze. Okay, ada soalan?
Doktor,
Ha.
kalau dalam HOPI kita mention positive relevant, dalam sistem review kena mention balik ke?
Yes. Dalam HPI you dah mention kan, dan systemic reviews, you just give summary je. Contoh macam, you can mention back, tapi usually just give a summary lah, better. Macam there's no GI symptoms, ataupun there's no ongoing losses. On gastrointestinal, there's no diarrhea vomiting. Macam tu lah. Okay. Sorry, ada pengumuman lah kat sini. Okay, macam ni. So in general, I think presentations are okay.
Excuse me, Doctor, I think your mic is muted.
Okay, hello? Ada soalan? Ada soalan tak? Any question? Hello? Dengar tak? You guys dengar tak?
No question, Doctor.
No question.
Okay, macam ni. I rasa kita boleh stop dulu. Next time, kalau when you in the ward, kalau you down
Doktor tak dengar.
okay, Assalamualaikum. You guys dengar tak?
You,
Baru dengar.
Okay, okay.
Baru dengar, Doctor.
Tangguh. Okay, tanggung dengan tasbih kafarah and suratul as.
Sekejap, Doktor. Doktor cakap next time in the ward. Lepas tu tak dengar.
Doktor dah tak ada lah.
Adalah.
apa nanti siapa yang contact doktor tadi? Yang
Aku.
Tira nanti tanya doktor cakap pasal apa pasal ward tu. Basically aku rasa dia suruh Clark dulu bila dia dekat ward nanti suruh present kat dia je. Okay.